Greetings and welcome to Lobes and Robes, How Neuroscience Can Change the World. This podcast is sponsored by the American University Center for Neuroscience and Behavior and explores the links between neuroscience and key policy questions today. I'm Susan Carl, a professor of law at American University Washington College of Law, and I will help lead discussions throughout our series. My co-host is Dr. Colin Saldana, a professor of neuroscience at American University. He is also the director of the American University Center for Neuroscience and Behavior and the president-elect of the Society for Behavioral Neuroendocrinology. This podcast is for anyone interested in how scientific discovery can make the world a better place. Thanks for listening.
Good morning. Our guest today is Dr. Jonathan Tubman, who is a professor in the Department of Psychology at American University. John received an AB in Behavioral Sciences from the University of Chicago and an MS and PhD in Human Development and Family Studies from Penn State. He held a postdoctoral fellowship at the Research Institute on Addictions from 1990 to 1993. He was a faculty member at Florida International University and has been a faculty member at American since 2011. Between 2007 and 2019, he held senior administrative positions in research administration and graduate education at both Florida International and American. During his career, he has served as the principal investigator or co-PI on multiple NIH-funded research projects and has served on over 100 theses and dissertation committees. His graduate training and ongoing research have been in the areas of applied lifespan developmental psychology, addiction studies, and social work. His areas of research and practice interest are centered on the applied developmental sciences of adolescence and emerging adulthood, with a special focus on vulnerable youth populations. John, welcome to the podcast.
Well, thank you for having me. It's great to be here this morning.
Welcome.
In broad strokes, John, how would you describe your research interests? Would you describe them as basic science, clinical science, or some type of hybrid?
I'm always going to vote for some type of hybrid, actually. A lot of my work is in the area of applied developmental psychology. So a lot of the work that I've done over the past 30 years really has been at the intersections of adolescent development, mental health problems, substance use problems, and health risk behaviors. I'm at AU. I'm a full professor of psychology. I don't have any degrees in psychology. My work I would characterize as broadly interdisciplinary.
Excellent. And what about juveniles and emerging adults make these populations of interest to you?
To me, this is really one of the most fascinating times in the lifespan in which one can do work. When we consider that adolescents are really changing from children to adults, they are experiencing cognitive changes, they're going through pubertal transitions, biological changes, but they're also being socially redefined. And this process, or these multiple interlinked processes, are clearly embedded in a historical context. The famous anthropologist Margaret Mead is credited with a statement that went something like this, that adolescence begins in biology and ends in culture, which really tunes us into the fact that there are biological universals to adolescent development, but that adolescent development is completely different depending on what culture and what historical era you're in. And I guess also in this era of rapidly changing technology, we have this concept of emerging adulthood, which is the period from, say, 20 years of age to 29 years of age, or maybe 18 to 25, which is completely different nowadays from what it was like even when I was a teenager, 45 years ago. We look at our college students today, they have totally different experiences from the ones that we have. So for me, it's a rapid period of change. It's a period of change that's the last good time to intervene in people's lives, to get them back on a developmental track towards optimal development. But it's just fascinating how much it's changed in just decades.
Yeah. Can you describe what some of the salient differences are historically?
Sure, absolutely. If you just look at the age of pubertal onset, if we go back to 1850, we see that boys and girls would basically go through puberty and reach reproductive viability at around 17 or 18 years of age, and they're ready to get married. So in 1850, we didn't even think about adolescents. Children were small adults. They went to work in factories. They helped support their families. Nowadays, we have children going through puberty at 9 or 10 years old, and they may be economically dependent on their parents until age 25 or 30 if they pursue extended graduate education. So, just the simple idea of negotiating your child's negotiating or adjusting to your child's sexuality and their reproductive viability is something that 150 years ago we didn't even deal with. I think the other thing, if you take something as simple as dating right now, and I love to use this example in my class when I teach lifespan development to undergraduates here at AU, I said, think about how the iPhone and apps and AI and algorithms has changed dating. When I was a teenager or a young adult, and my students are shocked when I say I've been married to the same man for 40 years now. They're shocked when I say, there was the principle of propinquity. You dated people who were, near you, and that you were reasonably attractive and could stand you and you could stand them. Nowadays, they've got thousands and thousands of people to pick from, and they're looking for something that, and I don't want to bust on the Gen Z crowd, but I think their ideas of what an acceptable life partner is completely different than when, say, people in an older generation were on the dating market, the marriage market. I'm just so glad I'm not dating. I never have to do that again.
Yeah, me too. And also, they don't seem to date per se. It seems like there's a lot, the hookup culture. I just have some stereotypic ideas in my head about what I seem to hear from my students, that there's not the sort of sense that early on they're looking for somebody who they'd be compatible with and have a relationship with. It's something more casual and shorter term. Or is that something that you're studying or finding?
I'm not studying it. I do study adolescent sexual behavior, and I have collected data about sexual behavior from emerging adults. But from anecdotally, what I hear is there's more of a likelihood to get into something called a situationship. And this was a new concept to me. But when I talk controversial issues in psychology, they educated me on the concept, but I think it would be what we call serial monogamy, but these are more casual relationships where you're free to date other people and it's nothing serious. It's a little more serious than just hooking up because you might actually like this person, but there's not necessarily any kind of commitment. And I've had these discussions with especially young women, and I just say, you actually sort of sound like some of the gay men that I grew up with. And I say to them, aren't you kind of selling yourself short a little bit if you are not expecting something a little bit more permanent? And, they start out with the argument that they're in control of their sexuality. I'm like, yeah, but maybe you deserve something more. And I've actually had follow-up conversations where they sort of say, yep, you may be right. It's interesting. Everything is changing, and it's changing rapidly, which is why I study adolescent and emerging adult development.
Makes total sense, John. Undoubtedly, your subjects are going through, especially the adolescent group, are going through a fairly tumultuous stage in their lives. And part of that may include brushes with law enforcement and the judicial system. How do courts look at juveniles in terms of development? Are they kids? Are they adults?
Fascinating question. And I think that depends largely on the state that you're talking about. Some states are much more progressive and have integrated developmental science into their juvenile justice policy. Other states really focus more on public safety, and they don't even really make an attempt, or even there's no performative attempt at really rehabilitation of minors. But philosophically and also in terms of the evidence, it brings up all sorts of debates about, for example, when can you hold somebody accountable? When does a child know the difference between right and wrong? We know the cerebral cortex doesn't mature until sometime in the third decade of life. When do we hold people accountable? And a case here in D.C. that really struck me, and I've been following it, was, and you probably have looked at this, a group of 4 or 5, 12 and 13-year-old girls kicked, stomped, beat a elderly cancer patient who's disabled from lupus to death. And part of me wonders, to what extent does the adolescent social brain and the susceptibility to social influence explain that behavior? To what extent is this a product of early trauma and adversity or exposure to systemic racism and poverty? To what extent is this really a sign of serious behavioral problems and psychiatric conditions that may or may not be treatable? When I see cases like this, I mean, they're extreme cases, but they bring up this whole discussion about to what extent should we be integrating developmental science into juvenile justice policy or law enforcement practices to understand to what extent people should be punished versus rehabilitated, or even the extent to which they can be rehabilitated, and what form should that rehabilitation take, and what is an appropriate sort of developmental span in which to do that. But most of the studies that I've done really are kids. They might be in substance use treatment. They might be in alternative schools. They might be really in regular public schools. But a lot of my work focuses on screening and using different kinds of person-centered analytic techniques to not look at the means of groups and the averages, but to identify particular groups of kids, small homogeneous subsets of kids who have multiple problems that may indicate specific developmental histories, and making recommendations to providers, to different kinds of service providers and policymakers about how to get those children or adolescents or emerging adults into developmentally appropriate, brief, selected interventions.
And are you finding that those interventions do succeed? Are they, if you do it right, do the results, are they promising?
I think there's a lot of evidence to suggest, for example, that brief motivational interventions, some interventions that are really 2 to 3 sessions long, can have immediate impact on things like HIV risk behaviors, on substance use patterns, heavy substance use patterns. Whether those can be sustained over time is another issue, but certainly there's a lot of evidence to suggest, especially for adolescents, right? You may go to an adult and say, here, I'm going to give you information, and with that information, you can change your behavior. Adolescents are completely different. Scare tactics generally don't work with them. Long-term appeals to health conditions they might have 30, 40 years from now, like COPD, you might say, you shouldn't smoke because you're going to get respiratory illnesses in your 50s and 60s. If you say that to a kid who might be shot on the way to school, or they might get hit crossing the road, or they have a life of grinding poverty, normative exploratory risk behaviors might be the most interesting and exciting thing in that kid's life. So, for example, trying to get adolescents who have very impoverished, marginalized lives to use condoms, for example, in reducing HIV risk for HIV exposure. Now, the sorts of things that you would use with adult white gay men who may be heavily resourced would probably not work with minoritized adolescents, simply because the things that motivate them are likely to be completely different. So some of my earlier work focused on creating developmentally appropriate, culturally competent interventions for adolescents in substance use treatment facilities around HIV risk reduction. But a lot of this does work for specific vulnerable populations of adolescents or early adults, but it really has to be developed in partnership with participants in those populations and really has to be tailored to their developmental needs.
As you described that, it sounds like such really important work, but I also think, isn't most of the solution trying to change the conditions in which kids are, growing up, which is something we seem not to be having much success at, or there's not enough dedication to that goal. But there are other interventions, even given the sort of social situation and the socioeconomic situation, that can help.
What you've just brought up is a struggle I have with academic psychology and have my entire career, which is why I went to really something that was more human development and family studies rather than academic psychology. I study people in context rather than bring them into a lab and expose them to an intervention. But there are, if you go to public health or sociology, if you're working with an interdisciplinary team, you know that the focus can't simply be on the individual. It really has to be on the family, and other intervention avenues have to be coordinated with, for example, the school or community settings, and that things work best if you are, for example, addressing individual behavior, parental socialization. Even the built environment where people live has to be addressed in order to address a social problem, which seems to be hard to mitigate.
You bring up something really amazing in my head, and by amazing, I mean confusing. How has society changing so dramatically in such a short time? How does that affect what you study, or how does it affect the specific topics you study?
Well, the great question. I mean, I started studying adolescent sexual behavior and its linkages to substance use problems in my postdoc, and sort of added to my work HIV risk exposure, or risk for HIV exposure in the 90s, and got some grants funded. Then all of the things changed, and HIV became, after 1996, more of a manageable health condition, and there wasn't as much funding for at-risk populations in the United States. I think, though, some of the basic questions that I study are transferable to multiple problems where we're talking about adolescents or young adults. The basic techniques of applying person-centered analyses to identify high-risk groups, I'm using the same kind of philosophy, research designs, conceptual approach that I was using 30 years ago to look at for adolescents who were at the highest risk for HIV exposure. Now I'm using those same strategies to look at LGBTQ emerging adults, and to look at groups of sexual and gender minority emerging adults who are at highest risk for intimate partner violence in their relationships. And the kinds of things that I'm finding are stunning and clearly has implications for how services are delivered, how service professionals are trained, and how counselors deliver different kinds of therapies, whether they're cognitive behavioral therapies or they focus on things like reduction of substance use, or they're just motivational therapies to change your life.
What kinds of things are you finding?
The fascinating things that I find is if you look at averages and you read public health research, you will see things like gay men or bisexual women or transgender individuals are at the highest risk. They're the highest risk groups for experiencing both forms of violent interpersonal aggression, but also intimate partner violence. But what I'm finding is that the majority of the samples that I've looked at, and I collected slightly over 1,100 surveys, almost 3 years ago, and have been analyzing the data ever since. What I find is actually it's a much smaller subset of people in those 5 different samples that I collected. And they have multiple problems. Like they are exposed to multiple forms of discrimination and stigma. They have substance use problems. They have pre-existing relationship problems. They have a history of lifetime trauma, both in childhood and ongoing trauma. So there's this whole nexus of influences that co-occur with intimate partner violence. And reducing intimate partner violence in these populations is not as simple as saying, well, we need to improve your safety and we need to get you out of that relationship. Because there's nothing to prevent that person from getting into another relationship. It really is they're embedded in a developmental system that promotes those experiences.
You know, John, as I'm going to preemptively apologize for this question, but I feel compelled to ask it. As members of the LGBT community, and I think you and I are probably a similar age, we were adolescents and emerging adults when people like us were dying everywhere. And then,
Sure.
Yeah, and as you know, in the mid-90s when I was in Los Angeles, the chorus that I sang with, we were singing at funerals, usually like once every week. And then, as you mentioned, in 1997, things changed and people stopped dying.
Mm-hmm.
Now, I look at the much younger LGBT community, I'm talking mainly about men here, with the advent of PrEP, or Truvada. How do you think these dramatic changes affect how people look at risk?
I mean, I look at the work of Stephen Russell. The guy has done great developmental work. And he talks about our generation, the AIDS generation. I was born in 1963. I didn't come out until, 1990 or 1986, 87. And I met my current partner 6 weeks after coming out. So I'm not a big risk taker in life. But I think today's youth think about HIV transmission as largely a manageable disease process like diabetes might be. They look at our generation as maybe sort of condom fascists. Because I think our generation was so traumatized and we thought of, sex as being equivalent to death. I mean, unsafe sex was equivalent to death. Now, unsafe sex, if you're on PrEP, you might catch another viral or bacterial infection, but that is seen as a nuisance rather than being largely stigmatized. It's seeing sort of the cost of doing business in many circles. Stephen Russell has this amazing article on the developmental collision between normative adolescent developmental processes and the coming out process. Our generation, most people came out in college. They waited till they got out of the house, till they were out from under their parents' supervision. They came out in college, and they might have even kept it quiet until they no longer were financially dependent on their parents. So they had the psychological tools to deal with coming out in a relatively more safe environment. Today, kids are coming out in middle school and high school in large part, whether that is expressing whether that they belong to a sexual minority group or a gender minority group. And what they're seeing, though, is an explosion of adolescent mental health problems because that is colliding with normative adolescent processes around peer group development. So in the quest for gender conformity and the masculinization or feminization of behaviors and trying to fit in and create an identity, these kids don't have the safety that we had in coming out in college. They're coming out in a very hostile peer environment. And so you're seeing things like cyberbullying and suicide occurring among kids who've been targeted and bullied. And we didn't have that.
That clears up a lot of questions in my head. Thank you.
Sure, absolutely.
Yeah, wow, that is really something I had never thought about. And in some ways, it's riskier and harder to come out when you're younger.
It is. I mean, I love walking across campus and seeing two boys or two girls. I mean, and at their age, they all look like boys or girls to me because they look like children. And even, there are a certain portion of AU students, I really can't tell what gender they are anymore. They all sort of look the same. So I try to be very careful with how I speak to people. But we didn't have that freedom. I mean, our generation was much more closeted and furtive about those things. Yeah, it's just a whole new world. And I guess some of my students can't even conceive of a time where you couldn't marry someone of the same sex, just like they can't conceive of a time where they didn't have cell phones to keep in touch nonstop with each other.
I'm going to ask, this is just so fascinating to me. I wonder about, this is something I've wondered about. It's kind of politically incorrect, but I'm going to go ahead and ask you all anyway. So what about sort of gender fluidity and sexual orientation fluidity over life, which, I would fall in that category. My sexual orientation has differed in different parts of my life. I worry sometimes that kids are locking in at a really early age and that their process through these issues over their lifetimes may continue, but there's sort of this push to like, I am this. I'm 16 years old and this is my identity, and I'm sure it's always going to be exactly like that. Do you come across any of those kinds of questions in the work that you're doing?
Sort of the opposite. The way I think about both gender identity development and the development of sexual identity is that this generation is in many ways taking advantage of a higher level of social permission to explore before committing. So, for example, whereas our generation, people got married, like my husband was married to a woman for 7 years and got divorced, and I met him 8 years after that. If I ask him why he got married, he's like, well, I wanted to get married. I was lonely. I felt I should get married. I don't think kids today feel that push to conform with traditional gender roles or roles around sexuality. They're much more free to explore. And so what we're not seeing is people coming out in their 40s, 50s, or later. They're doing this exploring up front. And I think their orientation is that they don't see this as something that they're then locked into. Many of them are very resistant to categorization. And I don't think that's necessarily unhealthy. I mean, there's a lot of research out there that suggests that women's sexuality in particular can be quite fluid and changeable over the lifespan. I mean, even if you go back to the Kinsey studies in the 40s, you can see that a large portion of both men and women had had a sexual encounter with somebody of the same gender that went all the way to orgasm. I mean, this is a long-standing part of American history, but one that is only now being destigmatized to the point where people are very nonchalant about who they are. I mean, and I think being in Washington and being in Ward 3 in Washington and being on this campus gives them permission to be who they want to be. And I mean, I am so jealous. I wish that my college experience could have been like that. I think it's wonderful.
I'm so glad that you talked about Washington, D.C., John, because I can immediately think of policies that come from your studies. And I do know that you are called upon to evaluate programs. Can you give us examples of the kinds of programs you evaluate or approaches?
I've worked with different research teams where we've evaluated brief motivational interventions for predominantly minority samples of adolescents. I did a lot of that work in Miami at Florida International University. I've also looked at brief motivational interventions for adolescent substance abusers in outpatient treatment facilities designed to reduce their risk for HIV exposure. Done a lot of work there that was funded by NIAAA and NIDA. And really, our recommendations were around effective kinds of brief, cost-effective treatments for adolescents who didn't have insurance, didn't have access to healthcare that would provide them much more intensive forms of treatment. So we were focused on getting services to adolescents before they develop substance use disorders. The work that I'm doing now, and so a lot of the evaluations really, I've never claimed to be either a lawyer or a neuroscientist. A lot of our evaluations were with self-report instruments because we were asking about substance use outcomes or sexual risk behaviors. The work that I'm doing now really is talking about more spending my time making recommendations about, the types of targets for counseling interventions. So really talking to like schools of social work, counselor ed programs at the master's level about how the content of interventions and how they deliver them, but also about the training of professionals working in healthcare settings, and also what service delivery organization should look like. And I'll give you an example. My husband, who's a bit older than I am, fell and broke his hip in November. And so he spent a week in Suburban Hospital, which, by the way, if you ever break a hip, is absolutely fantastic. They've got great orthopedic trauma surgeons there. Just a shout out for Suburban. But then he went to a rehab, and we like to think that we are so modern and up on the latest strategies for having an inclusive approach to healthcare provision. But when we were checking him in, one of the nurses who was there, who, clearly was from a very traditional developing country, probably very religiously traditional, said to me, "Are you the son?" I get this question sometimes, much to Tom's chagrin. I sort of said, "No, I'm the husband." And the person looked at me and just his face fell and he said, "Oh," and he left the room. And yeah, so it was an eye-opener that we live in a very privileged environment where, if you're white and you have money and you have higher education, you don't have to deal with stigma and prejudice and negativity all day. But imagine if you were living in either a Latine or an African-American community here in D.C. or elsewhere, where you're living in a very traditional, church-centered environment and trying to deal with coming out, where still being a sexual or gender minority, you are perceived as having a mental illness. And you either need to be fixed or you need to get out of the house, or you then have to wonder why so many kids, adolescents, so many minors are living on the street and trying to survive any way they can, whether it's participating in survival sex or the kindness of strangers or really having a really terrible time in terms of their health and mental health, but really being put on a track towards a very negative set of developmental outcomes. Those are the types of adolescents that I envision when I say I really am interested in looking at large data sets and isolating small homogeneous groups of people who need to be targeted for tailored, individualized interventions that meet their developmental and cultural needs.
It brings to my mind, John, a question about how far do your recommendations go? And by that I mean, you just told us about your evaluations and recommendations go to education, go to clinical fields. Do they extend up into the law?
Well, I mean, you mean in the current political environment? Absolutely not. I mean, I haven't necessarily worked with lawyers, but certainly if I look at something like AU's law school, there's a large portion of people who take on advocacy roles. So, I mean, I've never testified in court. I would make a terrible expert witness because I'm not good at taking complex developmental phenomena and responding to questions where someone wants a yes/no answer. I've never been good at that. I would probably be bounced off the chair in court very quickly.
Well, you would be prepped.
I'm sure heavily prepped. I think that there is a role for working with advocacy groups. And there's certainly a role as the number of people who go into the healthcare professions becomes more diverse, as we have more racial and ethnic minorities, and certainly as we have more sexual and gender minorities. You have seen a transformation about how healthcare is delivered, and there is a lot more attention to customer satisfaction, to continuous quality improvement, and a lot of what I'm working on can easily be translated into recommendations there. And every single article I write has a section on that. And I've even started to write, very short, maybe 3-page, not opinion pieces, but sort of viewpoint pieces, and tried to target them to like the Journal of School Health or the Journal of School Nursing or a journal that's read by a lot of pediatricians like the Journal of Adolescent Health. I try to write a short article distilling what I've done into, a very quick setup, but then end it with concrete, measurable recommendations for improvement of service provision or professional training.
And I'll just chime in here as the lawyer part of this trio in this discussion to point out that there is a legal backdrop through Title IX that does prohibit discrimination and harassment and based on sexual orientation and gender identity. It doesn't mean that it works, but that legal backdrop is there, although the current federal administration seems not to understand that at all or care. But in the longer term, I think those principles will, hold steady and provide, some backdrop to the other work that everybody is doing and needs to be doing. We're not starting from scratch around the legal landscape.
Yeah, it seems like the legal landscape is changing every 4 years or so, especially around things like Title IX. I know that right now, for example, the work that I do, it's clear it would not ever be funded. So there was a question earlier, because I'm interested in minority health disparities in particular. I think the key, though, is to try to be adaptable and try to think about how you can shape your form of inquiry to meet the current times. And I'll give you an example. The last study I did where we collected, 1,100 surveys around individual relationship and structural predictors of intimate partner violence among LGBT emerging adults. That study was done for $17,000. And a lot of it I paid out of pocket or through travel funds from the university, and I got some money from the department and the college. But it was done on a shoestring, and I did a lot of the work. But so far we've gotten 10 or 12 publications out of it and a whole bunch of work. So I'm doing another study this summer that'll probably be around $9,000, and I'm just going to pay for it myself in large part just to collect the data.
That shouldn't be. That's all I could say about that.
I'm doing NIH panel reviews, and they've been put on hold for 6 months. Universities are having their funding frozen, and you just wonder what's happening to their studies, their randomized clinical trials.
Well, the news is not so great on that front. The disparities are becoming more and more obvious. I want to be cautious about the time that we're spending, but are there any other thoughts or big challenges that you anticipate other than the current political climate in the development of your work, John?
I spent a chunk of 12 years of my career doing administrative work, and I'm thrilled to have retired from that and spend my time full-time doing research and teaching now. I guess just the enormity and the complexity of problems. We want to think that problems are simple, but they're so complex. I work in a department of psychology, but I see that a lot of the problems I study are embedded in larger developmental systems that are much harder, as Susan alluded to change. So it's just, staying optimistic, focusing on the small things that you can do in the time that you have, and thinking about I'm trying to do applied developmental work that has a translational function in the modest amount of time that I have left in my career that will improve the lives of people, and trying to keep that at sort of a manageable level and not get too discouraged by, as you said, the clear health disparities that are emerging and currently getting worse rather than better.
I'll chime in here to say, I think I'm just a little bit older than you, so I have those thoughts all the time. But one of the wonderful things about what all of us do is that we do have students, and we are transmitting these motivations and these ideas to the next generation that's going to work on them. And, sometimes that really helps me feel better about the future.
Absolutely. And you can also look back on what some of your students are doing and be very proud that at least you facilitated their pathway forward. And I think that I find that heartening every semester about this time, now that I'm looking at the next group that's going to be graduating. It's one of the fulfilling parts of the job.
And maybe that's a hopeful note to end on.
I think
Absolutely.
Well, that's it for this podcast episode. Thanks very much for listening. And as always, we welcome your feedback at neuroscience.policy@american.edu. We hope you'll join us again for our next episode. And do let us know if there's anything in particular you'd like to hear more about.